Good afternoon, and welcome to this edition of HDSA and Me. Today, we welcome Dr. Erica Rapp from our HDSA Center of Excellence at the University of Colorado and Dr. Michael Shrift from our HDSA Center of Excellence at the University of Washington for a panel discussion on managing psychiatric symptoms in Huntington's disease. You can send a question at any time during the presentation. Just click on the chat function in the toolbar, type your question, and hit send. Your question will be answered during the session. This presentation will be available in about a week on HDSA's YouTube channel. On November 11th, we'll welcome Jennifer Simpson, HDSA's Assistant Director of Community Services and Advocacy, to chat with us about HDSA's advocacy efforts, including the HD Parity Act. You can register for these sessions by going to hdsa.org/HDSA and me. And now a little about our speakers. Dr. Rapp attended medical school at New York University School of Medicine. She completed her residency and her consultation liaison psychiatry fellowship at Icahn School of Medicine at Mount Sinai. She joined the faculty at the University of Colorado School of Medicine Department of Psychiatry in 2015. Here she is an assistant professor and the consultation liaison psychiatry fellowship program director. Her primary clinical work is as an attending on the University of Colorado Hospital Consultation Liaison Service and with the University of Colorado HDSA Center of Excellence. Dr. Michael Shrift is a professor at the University of Washington, Department of Psychiatry and Behavioral Sciences, and the Memory and Brain Wellness Center, Harborview Medical Center. Previously, he was at Northwestern University Feinberg School of Medicine in Chicago, where he was Division Director of Geriatric Psychiatry and Neuropsychiatry in the Department of Psychiatry and Behavioral Sciences, as well as the Director of Fellowship Training Programs. Dr. Shrift is board certified in psychiatry by the American Board of Psychiatry and Neurology. Dr. Shrift has over 30 years of experience in the care of patients with Huntington's disease. And now I'll turn the broadcast over to Drs. Rapp and Shrift.
Okay, so can everyone hear me? Hopefully. I'm just going to give a brief presentation on the neuropsychiatric aspects of Huntington's disease. I have several slides to show, and then we'll go from there. So this is the original article, journal article that was published by George Huntington. So George Huntington was a general practitioner in Long Island who his family were general practitioners, and actually his grandfather started that practice. And they noted in their practice, and they had multiple generations of people with Huntington, what was not named yet, Huntington's disease, that he noted a whole bunch of things that people with Huntington's disease now very well know. That he described the hereditary nature of the illness. He described that in a large proportion of people, the onset was in adult life. It had a grave and unrelenting disability, unfortunately. It's associated with abnormal movements, including chorea and dementia. It often led to inappropriate and uninhibited behaviors. And there's another unfortunate aspect, and we'll talk more about it in detail, that suicide is frequent. It tended to lack response to treatment, and it led to an early death. And so what I briefly will talk about today are the cognitive and behavioral complications of HD, including the cognitive issues and the neuropsychiatric issues, including apathy, irritability, depression, impulse control problems, as well as psychosis. Briefly touch on delirium, sexual and sleep problems, and also just a brief treatment overview. And hopefully the majority of this will be questions. So the brain is made up of large-scale networks, and one of the important networks in the brain is unfortunately involved in Huntington's disease. And one critical structure that is often, or is part of the illness that degenerates, is called the caudate nucleus. I don't know if you could see my cursor move, but this is the caudate nucleus. And this progressively atrophies over time, where you see widening of the ventricles with loss of the caudate bulge into the lateral ventricles. And this is an important circuit. And when you have damage to the circuit, you lose cognitive speed. So people have an impaired ability to organize information. They show a decline in attention, concentration, mental flexibility. They have what's called executive function impairment. It's the inability to synthesize information in order to produce a alternative solution to problems. It could involve also impaired visual spatial functioning. Problems with planning could also occur, and it affects a person's ability to initiate behaviors over time. In terms of the cognitive problems, family members frequently complain that the person's lazy, they won't do anything, but it's actually due to problems with the circuit. However, once a patient starts a task, they often are able to follow through. They tend to perseverate on things, on thoughts or behaviors, and they become sort of fixated on certain behaviors and thoughts to, unfortunately, the detriment of other activities. And they could also have problems with impulsivity that's added character for them. So they could be, upstanding citizen all their life, but then start to do things like stealing, gambling, inappropriate sexual activity. And a very, very common problem is irritability with poor anger control. This irritability could lead to temper outbursts, and it's the outcome of this loss of impulse control and confusion and feeling overwhelmed, again, related to dysfunction in that circuit. People with HD are often challenged with the inability to perform everyday routine tasks. They lose these abilities imperceptibly over time and easily become frustrated and irritated. The outbursts at times could become violent, and patients often quickly forget about the incident, but family members, they're often left upset and shaken. This is unfortunately too common of a problem. They can have problems with their memory. So unlike people with Alzheimer's disease, people with Huntington's disease lose memories about how to ride a bike or how to play an instrument or how to drive a car, and these progressively deteriorate over time. That kind of memory doesn't get affected in Alzheimer's disease, but it's often significantly affected in people with Huntington's disease. They could also have problems with perception, and the perception could involve emotional perception, like, for example, the inability to recognize emotion on other people's faces. And they can identify and remember the emotions, but they lack the recognition of these emotions that lead to difficulty in social relationships. They often lose perception over time. And so someone who's always punctual becomes late. They lose their internal clock with and have problems with objective time. They often have problems with spatial and smell perception. And another major problem is lack of illness awareness. So the person with Huntington's disease often loses the sense that there's something wrong with them. And it's not just overt denial. It's that they lose, on a neurological basis, the ability to understand what's wrong with them. They can have severe movements, and yet if you ask them, are you having any severe movements, they'll say, there's nothing wrong with me. That's a common kind of thing. They have what's called a no-sick nausea. And the neuropsychiatric features are not as consistent as the motor or cognitive features, but they often cause substantial disability. They could occur prominently early in the course of the illness. They could even be the initial features of the illness. There's a sort of a rule of thirds in people with Huntington's disease. A third of people present with a neuropsychiatric presentation. A third of people present with a movement disorder, chorea commonly, and another third present with a cognitive disorder. But long before they ever develop the movement problems, they often have neuropsychiatric difficulties. So the people with Huntington's disease who have the gene, they could have neuropsychiatric problems that vary from irritability to psychosis, but the particular prevalence of any of these symptoms vary on the stage of the illness you're in and the assessment methods that are used to gauge these issues and the populations that are studied. Got stuck there. Okay, go back. So the most common problem that occurs is a change in personality. And they could also develop other things like problems with anxiety and mood problems, as I mentioned earlier, with executive social cognitive understanding, and they could also develop psychotic features, hallucinations and delusions, having false beliefs. So there was a large study that consisted of 1,993 HD mutation carriers from 15 European countries, and these patients were assessed on 5 neuropsychiatric features: depression, irritability and aggression, obsessive compulsive behaviors, apathy, and psychosis. And as you can see in this graph, as the stages move on, all of these problems get worse over time. The most common problem, and the one that gets worse significantly over time, is apathy. But depression, irritability, obsessive compulsive behaviors also get worse over time. Depression is very common, and some depressive symptoms are reported up to 50% of patients at some point during the course of the illness. Major depression in Huntington's disease is very similar to the depression that you see in people without that illness, just the primary form of major depression. And it's often managed the same way. Major depressive disorder is part of the description that George Huntington gave in his first journal article on this. It has a very high prevalence. It's up to 30 to 40% of people with this have depression, and has a suicide rate that's up to 12 times that of the general population. Severe cases could also be accompanied by psychotic features, having false beliefs, delusions, or auditory hallucinations. So looked at a symptom level, depressed mood is reported up to 60% of people with Huntington's disease, depends on the assessments that are used. Again, suicide is very, very common, up to 12-fold increase in the general compared to the general population. And there's really 2 critical times that suicide is common: when the diagnosis is first made, and the second is when one begins to lose functional independence from their neurological dysfunction. So it's really important that depression and its severity is screened on any medical visit. And it's also important to initiate and communicate this issue to the providers that give medical care to the patient with Huntington's disease. One way to assess this is to question the person about their loss of interest, the feelings of guilt, and in fact, ask them about whether they're thinking about killing themselves, or do they have a plan to kill themselves. And the treatment, as I mentioned earlier, for the depression Huntington's disease is similar to the treatment that you would for any patient with major depression. It includes almost all the same classes of medications that are used, and even in very severe cases, electroconvulsive therapy that's used, and can be quite beneficial for some patients with very severe depression. But people with HD may be more sensitive to side effects, and that needs to be watched out for. So in general, psychiatric symptoms are really the most amenable to pharmacotherapy. They often respond quite well, the psychiatric symptoms, to adequate treatment. The motor symptoms, in particular, chorea is the most responsive to treatment. Unfortunately, cognitive symptoms and dementia are the least responsive. And another unfortunate fact is that there's a lack of clinical trials for psychiatric treatment in HD specifically. There needs to be much more clinical trials and much more evidence to guide clinicians of how to treat people with HD who have neuropsychiatric features. But most experts agree that depression in HD often responds well to antidepressants, and most commonly drugs such as the Prozac-like drugs, serotonin reuptake inhibitors. Obsessive compulsive behaviors, anxiety, irritability often respond also to those drugs. And you could use mood stabilizers like valproate or carbamazepine that helps with mood lability and impulsivity. Buspirone, there's a drug called buspirone that may help also with anxiety. And for people with psychosis, antipsychotic medications, both the older ones and the new ones, have been shown to be beneficial. Again, you have to watch out for side effects, and the newer ones, the atypical antipsychotics, in general have different but possibly less side effects than the older ones. Apathy, which is often difficult to treat, but at times benefits from a drug called bupropion, and there's other medications that could be used for that. And then there's non-medication treatments. Behavioral treatments for apathy and cognitive problems can be helped with structured daily schedules, giving the patient cues, helping with regular routines. When routines are changed, often people have difficulty who have HD. Daytime respite gives a social outlet for patients. It often relieves caregiver burden. And family members of all ages struggle with the interpersonal and financial and social stresses of the disease. And social work services are really valuable in helping individuals and families who suffer with HD. And this is really important, I feel, as well, is that even in people with advanced HD, it needs to be assumed that the patient's recognition and comprehension are preserved. Even if they have severe articulation problems, dysarthria or rigidity, or moving slowly, patients often appear more cognitively impaired than they really are, and it leads the patient to more frustration and the loss of dignity. So it's important that clinicians and family members avoid talking over the patient. The effectiveness of many non-pharmacologic interventions are often limited, unfortunately, by the patient's cognitive and behavioral status. But as with many aspects of Huntington's disease, the burden of maximizing the benefits from supportive therapies is really placed on the caregiver. And this is the typical progression of the illness over time. And as you can see, what I wanted to point out is that even before you develop the motor features, which is in this region here, the psychiatric and behavioral features often precede that. Even the cognitive features often precede the motor features. Okay. I think Dr. Rapp might have something that she might want to present, and then we'll take questions.
So thank you all for having me back. And yeah, I think it makes sense for me to present my slides, and then we'll take questions. So give me just one moment. All right. Okay. Do you all see just the slide or the presenter view?
We're just seeing the presenter view.
Just seeing the presenter view. Okay. I always have a little bit of trouble with doing presenter view. So I'm going to close out of that and just show you the slides. So Dr. Shrift's overview was, extremely comprehensive. I thought that I would add an area that has become like a particular area of interest for me for people who have HD, which is perseveration. So Dr. Shrift certainly touched on this. In getting involved with the HDSA Center of Excellence and really delving into the treatment of Huntington's patients, I found that, like Dr. Shrift mentioned, there's really a dearth of evidence to guide the psychiatric treatment of people who have HD in general. But I was particularly surprised that there was such a lack of information about treating perseveration, given that I found that it was a very, very frequent area of difficulty for both people with HD and their families or caregivers. So like I said, this has become a particular area of interest for me. So I'm going to focus on this for a few minutes. So there's been some different vocabulary used in the Huntington's literature to talk about this symptom. Dr. Shrift already mentioned a couple of the terms in his presentation. So the term that I prefer is perseveration. You can find a bunch of different definitions. There's no official kind of psychiatric definition of this, but this is one I like. I won't read it to you. You can all read it. But basically, perseveration, as it appears in Huntington's, is the repetition of thoughts or behaviors past the point where they serve a purpose to the person. I want to touch on obsessions and compulsions because these are well-established psychiatric terms, and these terms often get used in the Huntington's literature. Again, so this is the definition in the DSM-5, the Diagnostic and Statistical Manual that psychiatrists use as sort of their main resource to diagnose psychiatric illness. Basically, what obsessions are repetitive thoughts that are distressing to the person and cause anxiety and sort of go beyond worries that are proportionate to the situation. So someone who has fears of contamination may be afraid that no matter how many times, no matter how clean things are, they always feel like there are germs and contaminants around. So there are many different examples. That's just one. And compulsions, this is again the DSM-5 definition. Compulsions are done in response to their repetitive behaviors are done in response to the obsession. They typically, at least in the patient's mind, they go along with the obsession. So for example, someone with contamination fears can wash their hands many times, or a certain number of times. They may, clean repetitively. The key with compulsions is that they are meant to address the anxiety that's related to the obsession. So the reason that I bring this up is because my experience with working with people who have HD is that people very, very often have repetitive thoughts and repetitive behaviors. They're not really, they're not usually quite the same as people who have obsessive compulsive disorder. Their repetitive thoughts are sometimes anxiety provoking, but often not particularly anxiety provoking. And often the person is not necessarily even aware that they're having these repetitive thoughts. And it's their family or caregiver that brings it to my attention that the person is just talking repetitively about the same thing all the time, and the person's not even aware. And kind of the same with behaviors, that people can have very repetitive behaviors, but typically it's not in response to an obsession. So someone may clean repetitively, but they don't seem to be afraid of contamination. They just seem to kind of do it because that's what they feel moved to do. Of course, I'm not saying that's true for everyone, but that's been my experience, that predominantly these repetitive thoughts and repetitive behaviors are not nearly as distressing as they would typically be to someone with OCD. Sometimes the person's not even aware that they're doing it. And that is the reason that I prefer the term perseveration. There's sort of a compromise in the Huntington's literature, calling these obsessive compulsive behaviors instead of obsessive compulsive disorder. So they're very, very prevalent in Huntington's disease. they've been reported in about 20 to 50% of people who have these obsessive compulsive behaviors. So that's about a quarter to a half of people. And I would say that that definitely lines up with my clinical experience. Like Dr. Shrift mentioned, these can surface before someone gets clinically diagnosed with HD, before they develop noticeable cognitive symptoms, before they develop any significant movement disorder, sometimes years before. So the best study that I found really honing in on the prevalence in people who are gene positive and asymptomatic versus people who are more advanced, found that in pre-symptomatic people, 7% of people have obsessions. And again, I feel that they were using this term loosely. So let's call it perseverative thoughts. And about half that number had quote unquote compulsions, which I would probably call perseverative behaviors. And then in people with advanced HD, that was significantly higher. So it wasn't as high as the numbers reported in some other studies, which showed up to half of people having some sort of obsessive compulsive behavior. But you can see that a large number of people, as HD gets more advanced, have obsessive compulsive behaviors / perseveration. But it is really quite significant even in people who have pre-symptomatic HD. Like I mentioned, there is unfortunately very, very little evidence to guide medication use. Actually, the guidance typically comes from the literature on obsessive compulsive disorder, even though the symptoms don't really present in exactly the same way. Case studies are when a doctor writes about a patient or a few patients who they've treated successfully and what happened. So there are a few case studies looking at perseveration and response to medications. There are these are both SSRIs, selective serotonin reuptake inhibitors, which are medications that are used really, really commonly for depression, for lots of different types of anxiety, as well as for obsessive compulsive disorder. So there have been a couple patients who have been reported to benefit from sertraline, the brand name for that some people know by Zoloft, and one patient reported to benefit from fluoxetine, the brand name that a lot of people know as Prozac. There was a study that found benefit with olanzapine, brand name Zyprexa, but that looked at overall psychiatric and behavioral improvement. Perseveration was a component of that, but they didn't separate it out. There was a survey of experts that was done 10 years ago that found that for medications, people typically said that they use these SSRIs, and sertraline and fluoxetine are in that category. Olanzapine's in the antipsychotic category. And also people recommended cognitive behavioral therapy, which is a common type of therapy that's used for many things, again, including OCD. But this is really only going to work in people who have very mild cognitive impairment or do not have any noticeable cognitive impairment. So, this is, I think that this survey study demonstrated that people had a general practice that makes sense, but there's not actually enough real evidence in the literature to verify that these treatments actually work, or say that they don't work. So I I and my group have kind of come up with some guidelines for family and caregivers. These are certainly not ideas that are unique to us, but we these are kind of the things that we typically recommend to people. One is prevention. If there is a certain situation that triggers perseverative thoughts and perseverative behaviors for someone, if it is possible to avoid that situation, it is, it's ideal to avoid it. So that's certainly not always possible, but that is one thing that we always mention, in case the situation can be avoided. The second thing is redirection. Sometimes, especially when people have behavior that's that's sort of mild to moderate, it goes on for a long time, but it's not a severe behavior. Sometimes they can be very redirectable, particularly after they start taking a medication for the perseveration. And sometimes the family or caregiver can simply say, let's, that's great. You did a great job. Let's go over here and eat lunch, or, something like that. That does sound kind of simplistic, and it can actually require quite a bit of effort. And it can sometimes the person with HD will sort of need to hear that really frequently, but sometimes that can be a really effective strategy. So one thing that that really seems to work for certain types of behaviors is gradually modifying the activity. So, for example, if someone is repetitively rearranging knickknacks on a shelf, for example, then that a caregiver may be able to help that person sort of expand that activity into, dusting a whole room. Or obviously, I'm not suggesting that that anyone kind of take advantage of perseverative behavior to get people to do housework, but sometimes a perseverative behavior can be kind of redirected into something that is that is similar but more productive. And then finally, sometimes I find that families and caregivers get very, very anxious and about perseverative behaviors in particular, and they find them very upsetting, and that is completely understandable. Sometimes it's okay to just ignore a behavior if it's not causing problems. If someone's behavior is very repetitive and taking up a lot of their time, but it's very difficult to redirect them, and you haven't been able to either think of something productive to kind of turn the behavior into, or it doesn't work, and the behavior is not causing problems, it's okay to ignore it. So those are kind of the main points that we talk about for families. I have a large number of references and further readings for anyone who's interested, and I can certainly share this little slide deck. I know can't actually see the time on my screen, so I know that I know we want to leave a lot of time for questions. So I will wrap up there and stop my screen sharing, and we can take a look at the chat and take some questions. All right, so it looks like Dr. Shrift has already answered the 2 questions that came in. What other questions do people have?
As a reminder, folks can ask questions through the chat box. Just go to the chat feature at the bottom of your toolbar on the Zoom screen, type in your question, and then just press enter. Well, I get us started off on a few. Perhaps we can chat a little bit about, what are the psychiatric symptoms that present most often in your Centers of excellence?
I could go or you could go. Depression is probably the most common. Depression is the most common. Yeah, and the other is apathy. So both of those are. Depression is much more treatable than the apathy, but apathy progresses throughout the course of the illness.
What are some of the strategies that families can use for treating apathy?
Yeah, so I sort of mentioned it earlier. Having schedules for people and a structured day and routines, that really helps. If you leave the planning up to the person with HD, it often doesn't get followed through. But if they're in a structured situation where there's a routine and there's a plan for the day, often that helps the apathy. There are some pharmacologic strategies as well. As I mentioned earlier, bupropion has been used. Even at times you could use other sort of stimulant medications at times if the apathy is very severe. But typically having a structured day where it's already sort of help planned out helps apathy a lot.
Yeah, and I that completely lines up with my experience. Like Dr. Shrift said, I see depression very commonly. It's also quite treatable as long as I know about it. Sometimes the person with HD will not really be that aware of being depressed, and I'll really get that information from the family. But it does seem to be very treatable. Like Dr. Shrift, I also see a lot of apathy it's definitely harder to treat. I'd also add, it's hard to say whether I see it because I'm particularly interested in it and I look for it, but I definitely see a lot of perseveration, and I also see quite a bit of irritability. Sometimes people have the impression that many patients with HD have kind of a physically aggressive behavior, and that certainly does happen. But what I see more is people being very impatient and very very irritable when things aren't happening as quickly as they want. So I would add those two. I would agree they're not quite as common as depression and apathy, but I do see them quite frequently.
Let me add just a couple of things though, in terms of apathy and depression. So it's sometimes difficult to differentiate the two because many patients with depression are also apathetic. But what differentiates depression from apathy is that people with apathy don't have typically the psychological symptoms of depression, feelings of hopelessness, feelings of guilt, feelings of worthlessness, feelings of they want to die or suicidal ideas. People with apathy are mainly just avolitional, as opposed to people with depression who they often have a sleep disturbance, an appetite disturbance, and have those psychological symptoms of depression. And when you see that, that's a very treatable syndrome of depression.
So we have a question here. Any thoughts or suggestions on how to handle spontaneous situations that arise in life and the HD patient is unable to be flexible? For example, my husband has difficulty rethinking situations when they change. Travel is extremely difficult. Yes, that is a difficulty that I certainly hear a lot about. I have found that, a couple things. One, medications can help with that. I've used the SSRIs, again, like Zoloft, Prozac, with some success for that. I also typically advise people to kind of think in advance about contingencies as much as possible. Obviously, that is not 100% possible because unexpected things do happen in life. But I think the more that you can plan in advance for things that are typically difficult, for example, is it difficult when you have a particular plan and the plan falls through? Is it difficult when the weather does something unexpected, so you have to change your plans? Or like what are the specific difficulties? Then sometimes you can plan for at least some of those in advance.
I guess there's a question about which animal model is best to study Huntington's disease. And there's MAM. I'm not sure what that is, but the animal model that's been most used is a mouse model in terms of the effects of the mutation on physiology. So it's a mouse model that's been mostly used. Hopefully that answers your question.
We have another question. How can families work with healthcare professionals to document psychiatric symptoms for disability purposes? So this would be for the purposes of someone receiving SSD. Is that the question? Okay. So, I mean, I can comment on what is helpful to document from the standpoint of kind of providing clinical care. I have to say, I don't know that there would be anything specific to a disability application. In my experience, the disability, like when people go on disability for HD, it's typically for cognitive symptoms. So sometimes it is motor, they're sort of movement symptoms that get, that get very bad and make it so that the person can't work anymore. And that would be documented by the neurologist. For cognitive symptoms, people would typically get neuropsychological testing.
Is it okay?
Yeah, go ahead.
Okay. So yeah, even I mainly deal with people with dementia, and so this is a thing I do every day. That even things like the Montreal Cognitive Assessment Battery, documents what their cognitive impairment is. And typically people with Huntington's disease have problems with what I mentioned earlier, executive function. And that's a good instrument to assess executive function. The other thing is that in order to document disability, you have to show that there's impairments in activities of daily living. What's called personal and instrumental activities of daily living. So like cooking, household chores, grooming, driving, toileting, walking, all your activities of daily living. In order to diagnose dementia, it's not enough to have a cognitive impairment. that cognitive impairment has to result in a social and occupational impairment. And that's documented by activities of daily living. And so if you could show that the activities of daily living are impaired together with cognitive impairment, they would meet the criteria for disability. Hopefully that helps.
Dr. Shrift, have you ever seen someone with HD go on to disability for psychiatric reasons specifically?
Absolutely.
Mhm.
And often, sometimes the insurance company balks at that, but you just have to show them the literature that this illness begins long before the movement disorder begins. And there's tons of evidence for that now.
Right.
Yeah. So yeah, but yeah, I've had people who've had repeated suicide attempts, multiple psychiatric hospitalizations, and they tested positive for HD but don't have movements. And a famous insurance company wound up covering this. So it was was involved in a legal case. So yeah, there's a question: yeast as a model organism for neurodegenerative disease is better as compared to mouse model. Okay, it depends what you're really researching. It depends on the research question, really. But that might be true. You guys have other questions for us? We welcome any and all questions.
I can see we have a somewhat shy group here, so I'll jump in with questions. So basically, I asked earlier a question about how often do psychiatric symptoms appear as the first symptom of Huntington's disease, and I believe that Dr. Shrift has answered that was about a third. So do you find that when people are presenting with psychiatric disease, with psychiatric symptoms first, that they are more amenable to treatment versus disorder, or are they equally, acceptable treatment?
So in general, the psychiatric symptoms are one of the most treatable parts of the illness. But this is a common scenario. People present with a schizophrenia-like illness, or a major depression, or a manic depressive, bipolar-like illness, or personality change, and it's often not, diagnosed as part of Huntington's disease, and until someone gets the gene for HD. So a lot of people present to psychiatrists, wind up in psychiatric hospitals, even long-term psychiatric hospitals, with a diagnosis of schizophrenia, and they don't actually have that. They have a schizophrenia-like illness, but it's from Huntington's disease, until someone thinks about their family history and gets the proper genetic testing. So I've seen patients, I can't tell you how many times this has happened, that people who were had actually HD were diagnosed with schizophrenia and developed abnormal movements, and it was thought those abnormal movements were tardive dyskinesia, where in fact the movements were from Huntington's disease, and the person never really had the primary form of schizophrenia. They had a schizophrenia-like illness, but it was attributed, not to HD. And so this is a common problem, because it becomes obvious to everyone that when someone develops chorea, then it's probably HD. But before that, the symptoms are not much different than people with the primary psychiatric disorder. So the major depression looks like major depression that you would see in anyone that would develop major depression. It may not be different. And if they have mania or psychosis, it may look exactly the same. It's only when someone gets the gene, or they manifest chorea, then the index of suspicion goes up higher that it's all related to HD.
Do you think that when someone goes to their local primary care provider or local neurologist, and they know that there's a family history of Huntington's disease, do you think that there's more likelihood that the healthcare provider will encourage genetic testing in order to explain their symptoms, especially if they're not movement related?
I would hope. I would hope that's true. I do think in general it's true. I know, most of my career has been in tertiary care medical centers, so I already see a select population. A lot of patients I've seen, who've gone to community centers or private practice psychiatrists it may not be tested, and you in order to do DNA testing, you have to manifest a feature of Huntington's disease for the insurance company to approve the testing. And so if you have someone who's asymptomatic, they actually have to see a neurologist, they should see a psychologist or psychiatrist and a geneticist before they get the testing, because of issues regarding suicide when the diagnosis is made, and whether the person is able to accept that diagnosis, and they need to be followed over time. And so it's a complicated thing about testing. If someone is manifesting the features of Huntington's disease, let's say they're in a hospital and they have chorea, then you could easily order the DNA testing. But someone who's asymptomatic or with what looks like a primary psychiatric problem, it becomes more problematic to get HD gene testing. Hopefully that answered your question.
Yes, absolutely, you did. And thank you very much for bringing up, predictive testing and the need for talking with counselors prior to that, so they have a good result.
Right. Right.
Is there anything else? We are running out of time. Is there anything else that you or Dr. Rapp would like to add for our audience that we haven't thought to talk about yet?
I just want to emphasize there needs to be more clinical trials and needs to be more focus on the neuropsychiatric aspects of this illness. And I'm sort of biased here, but the neuropsychiatric aspects of this illness are the most disabling part of the illness. Patients rarely ever complain of the chorea. It's family members that complain of the chorea. Patients often even aren't aware that they have chorea. It's the neuropsychiatric problems, apathy, depression, psychosis, obsessive compulsive behaviors, perseverative behaviors. All those things are the most problematic part of the illness.
That's one of the reasons I asked about disability, because many of our families struggle for quite some time to qualify for SSDI because they don't have that hallmark movement disorder. And HDSA has worked hard with SSA to try to broaden their criteria for determining disability. The psychiatric symptoms still somewhat problematic unless there is a secondary symptom that SSA can kind of point to, either cognitive decline or the movement disorder.
Right. So, but if you have you're positive for the gene, it'd be hard to argue that the psychopathology the person has is from some other cause.
Mm-hmm.
Especially with the tons of literature supporting that in terms of brain imaging, neuropsychological testing, and again, as you mentioned, psychiatric morbidity. And so it'd be hard. This illness doesn't begin the day you develop chorea. It begins decades before that. You've had this gene since birth. It begins slowly and insidiously, but it begins long before you develop chorea. If you wait for the chorea to develop, you've already selected people late in the illness. You have to really, if you're going to do research to halt the progression of this illness and have disease-modifying treatments, it needs to be much earlier.
That's very true, and I think that that is a challenge for most of the community.
Right. You guys have other questions?
We do have someone who's asked a couple of times, what is the main role of NRF2 in Huntington disease? Are either of you familiar with it?
Yeah, so it's a small molecule, and it's currently in research trials, and there's been some equivocal outcome in terms of whether it helps or not. Much more research needs to be done.
Thank you. I just want to make sure we covered all the questions
Yeah.
that had come in.
Yeah.
All right. Well, it appears that we don't have any further questions. I would like to thank both you, Dr. Shrift, and you, Dr. Rapp, for this really wonderful presentation on managing psychiatric conditions in Huntington's disease. You both are really wonderful speakers and fonts of knowledge, and I do hope that both of you will be available for additional webinars in the future. You were great. I appreciate it.
Thank you. Thank you for the invitation.
Thank you so much.
All right, so we are going to wrap up now, and I just want to remind folks that our next HDSA new webinar will be in November when Jennifer Simpson joins us to talk about advocacy and the HD Parity Act. Till then, I hope you all have a great day and take care. Bye-bye.
Thank you. Thank you.
You too.
Well, thank you, Dr. Rapp. And it was
Yeah,
fun working
thank
with
you so much.
Yeah.
You too.
Thank you.
Nice to meet you.
And nice to meet you. Hopefully we'll meet again.
I mean, agreed. All right, take care.
Okay.